It's a pleasure to be with you. The title of this talk is Improving Healthcare Immunization Rates. There are no disclosures for this presentation. Objectives include review the ACIP recommendations for the immunization of healthcare personnel, review data on healthcare personnel immunization rates for influenza vaccine, briefly review the issues discussed at the National Foundation of Infectious Diseases Healthcare Personnel Immunization Summit in 2017 and their potential applications to healthcare immunization programs, and discuss practical roles of the 6 major stakeholder groups associated with healthcare personnel immunization programs. Immunizations save lives and are one of the most important primary prevention tools of public health worldwide. Healthcare is one of the largest industries and employers in the United States with more than 8 million employees. So appropriately immunizing this large group of people in regular contact with millions of healthy and ill individuals is extremely important for the health and wellness of the public. Healthcare personnel leading by example is also helpful to improving immunization rates of the public. Much of the content of this talk comes from the MMWR article referenced on this slide, Immunization of Healthcare Personnel, Recommendations of the Advisory Committee on Immunization Practices, ACIP, and the NFID webinar, Improving Healthcare Personnel Immunization Rates from 2017. This slide lists the immunizations recommended by the ACIP, the CDC's Advisory Committee on Immunization Practices for healthcare personnel. Generally, all healthcare workers should be immunized with hepatitis B, influenza annually, MMR, varicella, and Tdap, particularly to provide immunity against pertussis. For laboratory workers who handle isolates, additional immunizations are recommended, including meningococcal, typhoid, and polio immunizations. So who is a healthcare worker? That question defines the parameters or boundaries of a healthcare personnel immunization program. The Centers for Disease Control and Prevention lists physicians, nurses, emergency medical personnel, dental professionals, medical and nursing students, laboratory technicians, pharmacists, hospital volunteers, and administrative staff. The National Foundation of Infectious Diseases, NFID, Call to Action Group felt the CDC's list may leave some gaps and further defined healthcare personnel eligible for immunizations as all individuals who have patient contact in clinical settings, including hospitals, long-term care, rehabilitation, urgent care, home health, and emergency medical services facilities. The major point from the Call to Action group is to immunize anyone in a clinical setting who has patient contact. Let's start with some discussion of hepatitis B vaccine. Hepatitis B vaccine was the first anti-cancer vaccine developed, preventing liver cancer as shown in this picture. Hepatitis B is a DNA-containing virus that causes liver infection. Hepatitis B is highly contagious and transmitted percutaneously or by mucosal exposure to infected blood or body fluids. It remains viable on surfaces for up to 7 days and can be transmitted in the absence of visible blood. Symptoms of hepatitis B include anorexia, malaise, abdominal pain, nausea and vomiting, jaundice, and extrahepatic symptoms like skin rashes and arthralgia. About 30 to 50% of adults infected with hepatitis B will be symptomatic. The fatality rate for acute hepatitis B infection is less than 1.5%, but higher in those over 55 years old. Fulminant infection is fortunately rare at less than 1% of cases, but when it occurs, it may result in death or liver failure requiring transplantation. Chronic infection develops in 90% of children infected during infancy. Less than 1 to 12% of those infected as adults will develop chronic hepatitis B. Chronic infection is more frequent in those who are immunosuppressed or have diabetes. People with chronic hepatitis B have a 15 to 25% chance of premature death from cirrhosis or liver cancer. Hepatitis B is the most common cause of hepatic cancer in the world. It's estimated that from 850,000 to 2.2 million individuals in the United States are chronically infected with hepatitis B. This slide lists recommendations for hepatitis B vaccination for healthcare workers. There are 4 hepatitis B vaccines that can be administered to adults. The aluminum adjuvanted vaccines, Engerix B and Recambavax HB, a hepatitis A and B combination vaccine called Twinrix, and a relatively new adjuvanted vaccine called Heplisav B. Engerix B, Recambavax HB, and Twinrix are given in a 3-dose series, or Heplisav B in a 2-dose series, and should be administered to healthcare workers upon hire if they have no evidence of a previously completed hepatitis B vaccine series from immunization records or a state registry, or serologic evidence of hepatitis B antibody greater than or equal to 10 international units per milliliter of anti-hepatitis B surface antigen antibody. The 3 doses of Engerix B, Recambavax, HB, and Twinrix should be given at 0, 1 month, and 6 months after the first dose. Serologic testing should be done 1 to 2 months after series completion. After completion of the first hepatitis B series for non-responders, or those who have a negative serologic response, less than 10 international units per mil, there are 2 accepted approaches. Give 1 dose of the vaccine and retest serology in 1 to 2 months. If still negative, complete the series and repeat the serology 1 to 2 months after the last dose is completed. If still negative, label as a non-responder. No further vaccine is currently recommended. An alternative to the 1-dose approach is to just give the whole series and retest serology in 1 to 2 months after completion of the series. If the serology is still negative, label as a non-responder. No further vaccine is currently recommended. No retesting is necessary for healthcare workers with documented post-vaccination immunity via serology, since once having documented serologic conversion, even if the antibody levels drop below 10 international units per milliliter, protection for greater than 30 years has been demonstrated. There is a new vaccine, Heplisav B, developed by Dynavax. It was licensed by the FDA on November 9, 2017. It is an adjuvanted vaccine administered in a 2-dose regimen that may increase series completion compliance. Heplisav B vaccine is composed of a yeast-derived recombinant hepatitis B surface antigen and an adjuvant. The 1018 adjuvant is an immunostimulatory cytidine phosphate guanosine design that binds toll-like receptor 9 to stimulate a directed immune response to hepatitis B surface antigens. Toll receptor 9 in humans is expressed in various immune system cells, including dendritic cells, macrophages, natural killer cells, and other antigen-presenting cells. This is a study comparing seroprotection rate percents between Hepatitis with Engerix B in those 40 to 70 years old. Note that the endpoint was at 12 weeks for Hepatitis B versus 32 weeks for Engerix B. There was a significant difference between seroconversion rates, 95% for Hepatitis B and 81.3% for Engerix B. Other studies have shown similar seroprotection rates. For Hepatitis B, ranging from 90 to 100% versus the comparison group at 70.5 to 90.2%. This shows the comparison of Hepatitis B in compromised patients to the comparison group immunized with current vaccines. For type 2 diabetes, the Hepatitis group had a seroconversion rate of 90% versus 65.1% in the comparison group. For chronic renal disease patients, the 3-dose Hepatitis group had an 89.9% seroconversion versus 81.1% in the 4 double-dose comparison group. The 2019 adult hepatitis B immunization schedule includes that the CpG adjuvanted hepatitis B vaccine, Hepatitis B, can be used for individuals 18 years old and older. Influenza is a serious disease and kills. Each year, 3,330 to 49,000 people die of influenza in the United States, with an average of about 36,000 deaths per year. Annual influenza vaccination is recommended for all healthcare personnel that have patient contact. It should be given as soon as it becomes available each year and is most beneficial if given before the end of October. Contraindications include a person with severe life-threatening allergies to vaccine components like gelatin and antibiotics, etc. Egg allergy is no longer a contraindication for influenza vaccination. CDC studies have shown that there is little, if any, risk of severe allergic reactions when vaccine is given to those having egg allergies. People with egg allergies don't need to be observed for 30 minutes after the vaccination, as was previously recommended. For individuals with a history of severe allergic reactions to eggs other than hives, if reasonably possible, they should be vaccinated under the supervision of a healthcare provider who is able to recognize and manage severe allergic conditions, though as previously stated, those reactions are extremely rare. Severe egg allergy most commonly results in anaphylaxis, represented by the following symptoms: constriction of airways resulting in difficulty breathing, abdominal pain and cramping, rapid pulse, and shock manifested by a severe drop in blood pressure with dizziness, lightheadedness, or loss of consciousness. There is little data available on vaccination rates among healthcare personnel, since there are no requirements to report this kind of data, and as a result, there are no good state or national data sources for healthcare personnel immunizations. CDC does have some data on influenza vaccination rates that will be presented in the next few slides. This slide reviews influenza vaccine coverage for healthcare personnel from the 2014-15 season. Early season coverage was 62 to 64%. Late season increased by an additional 9 to 12% over early season rates, getting to a maximum of approximately 71 to 76% coverage at the end of the season. This is data from a CDC internet survey for influenza vaccine coverage by work setting completed in November 2017. Hospitals had an 82.6% coverage, followed by ambulatory care at 68.7%, long-term care at 58.5%, and other settings at 56.2%. The relatively low coverage in long-term care is of concern. The elderly, those over 65 years old, are at risk for more severe disease and death. Protection by vaccinating long-term care professionals would help reduce influenza exposure for the elderly. Up to 85% of seasonal flu-related deaths and between 54 and 70% of seasonal flu-related hospitalizations occur in people 65 years and older. Increasing immunization rates of healthcare personnel in long-term care should be a target for public health immunization efforts. This slide reviews influenza vaccine coverage of healthcare personnel by occupation in 2017. 86.4% of pharmacists had been vaccinated, followed by physicians, 82.7%, nurses, 82.2%, nurse practitioner, physician assistants, 79.7%, other clinicians, 75.1%, administration and non-clinical support staff, 61%, and assistants and aides, 56.2%. We must increase healthcare personnel influenza immunization rates for all occupation groups, with a special focus on the lowest groups listed in this table: other clinicians, administration and other non-clinical staff, and assistants and aides. This slide shows the impact of facility influenza vaccine policy on coverage rates. Mandatory requirements for annual vaccination resulted in a coverage rate of 85.8%, followed by policies that just recommended vaccinations at 68.4%, and in facilities with no influenza vaccine policy, only 43.4% were vaccinated. A major point: mandatory policies increase influenza vaccination rates. This slide lists the most common reasons healthcare professionals chose not to get an annual influenza vaccination. The 5 major reasons include concern about side effects or getting sick from the vaccine, 22.1%. I do not need the vaccine, 15.3%. This would seem to indicate an underestimation of the risks of influenza disease. I think the components of the vaccine are not good for me, 15.1%. I don't believe the vaccine works, 14.5%. How can this reason even be considered by trained healthcare personnel? Last, I'm allergic to the vaccine or have another medical contraindication, 10.5%. It seems all of these reasons are related to incomplete or inaccurate knowledge and could be addressed by appropriate education of the healthcare workforce. This slide lists influenza vaccine efficacy since 2011. Vaccine efficacy varies greatly from season to season. The overall adjusted vaccine efficacy ranges from 19 to 52%. In the 2017-2018 season, it was 36%. Even with low efficacy, the vaccine decreases influenza disease severity in those infected, particularly in children. With individuals at risk, there is a 50% decrease in severity of illness, and with healthy individuals, there is a 65% decreased severity. Influenza vaccine is our best defense against influenza. Let's now briefly discuss measles, mumps, and rubella vaccine, the MMR. From January 1st to July 14th, 2018, 107 people from 21 states had been diagnosed with measles. From January 1st to June 16th, 2018, 47 states and the District of Columbia in the United States reported mumps infections in 1,447 people. Rubella, associated with congenital rubella syndrome, is relatively rare in the United States, but causes approximately 10 cases each year. Even though rare in the United States, other areas of the world still have endemic rubella and can carry the infection to the United States. For example, there was a major rubella epidemic in Japan in 2013. The MMR vaccination schedule is 2 doses separated by at least 28 days. Healthcare workers need to document their immunity in 3 ways: having had 2 doses of MMR, have laboratory evidence of immunity, or laboratory confirmation of disease. This criteria also applies to those born before 1957. In the past, it was assumed that those born before 1957 had been infected with these common childhood viruses and were therefore immune. Even with a history of immunity, like having 2 doses of MMR separated by at least 28 days, healthcare workers should still use N95 masks when working with measles patients. One healthcare worker who had a documented history of 2 MMRs was infected with measles after prolonged exposure to an infected patient. Using an N95 mask could potentially have prevented this infection. Varicella is a highly contagious illness, and though often self-limited, can cause overwhelming infections and death. The risk of hospitalization and death from chickenpox is increased in adults. Chickenpox can cause complications such as pneumonia or encephalitis. Adults are 25 times more likely to die from chickenpox than children. About 90% of unvaccinated household contacts of an infected person will catch chickenpox. It is estimated that each year, more than 3.5 million cases of varicella, 9,000 hospitalizations, and 100 deaths are prevented by varicella vaccination in the United States. The varicella vaccination schedule is 2 doses separated by 4 weeks. Healthcare workers need to document immunity in 3 ways similar to that with measles, including history of 2 doses of varicella vaccine, or laboratory evidence of immunity, or laboratory confirmation of disease. Pertussis or whooping cough is a common respiratory infection and is particularly dangerous for young children. These tables are data from 2017. 55.7% of the hospitalizations occurred in those under 1 year old. 68.3% of the infections occurred in those over 7 years old. There were 13 deaths in 2017, with 4 being in the less than 1 year old age group. The main goal of pertussis vaccine is to protect young children while they build their immunity to pertussis from the primary immunization series. The schedule for healthcare professionals is Tdap as soon as possible, if not previously given. TD is then given every 10 years thereafter for protection against tetanus and diphtheria. Pregnant healthcare women need to get a Tdap with each pregnancy, best if given during the 3rd trimester between 27 and 36 weeks gestation. Pertussis vaccination gives no permanent immunity. An individual can be reinfected multiple times during their life. So we've covered the general immunizations for all healthcare personnel that have contact with patients, including hepatitis B, influenza annually, MMR, varicella, and Tdap. For laboratory workers who handle isolates, additional immunizations are recommended, including meningococcal, typhoid, and polio immunizations. Laboratory personnel that handle specimens should get both the quadrivalent meningococcal conjugate vaccine and meningococcal B vaccine. There are two quadrivalent vaccines, Menveo and Menactra, both given in one dose to adults. Menveo is licensed for those from 2 to 55 years old. Menactra is licensed for individuals from 9 months to 55 years old. There is no current meningococcal vaccine licensed for those over 55 years old. The CDC recommends giving Menveo or Menactra off-label for those at risk, like microbiologists who are over 55 years old. Microbiologists should receive a booster dose of quadrivalent conjugate vaccine every 5 years. There are two meningococcal B vaccines, Bexsero and Trumenba. Both Bexsero and Trumenba are licensed for individuals 10 to 25 years old. Bexsero is given in 2 doses separated by 1 month. Trumenba can be administered in 2 different schedules. 2 doses separated by 6 months for healthy individuals who are not at risk, and 3 doses at 0, 1 to 2 months, and 6 months for individuals at risk or during outbreaks. Microbiologists are considered at risk. Therefore, the ACIP recommends either the 2-dose Bexsero series or 3-dose Trumenba series for that group. The ACIP in their June 2019 meeting voted to recommend booster doses for individuals with complement deficiencies, complement inhibitor use, asplenia, and microbiologists at 1 year post-primary series, followed by booster doses every 2 to 3 years thereafter for as long as risk remains. These vaccines will need to be used off-label for those over 25 years old. Both the quadrivalent and meningococcal B vaccines can be given at the same time, but at different sites. There are 2 typhoid vaccines, TY21A Vivotif and a VI capsular polysaccharide vaccine, Typhim VI. TY21A Vivotif is an oral vaccine given every other day on days 1, 3, 5, and 7 for 4 doses. The Vivotif series needs to be repeated every 5 years. VI capsular polysaccharide vaccine, Typhim VI, is an injectable vaccine and must be repeated every 2 years. The last vaccine to consider for laboratory workers is inactivated polio vaccine, IPV. Poliovirus is a risk for microbiologists since it can persist in specimens like stool specimens for decades. An unvaccinated adult should get a 3-dose series at 0, 1 to 2 months and a 3rd dose 6 to 12 months after the 2nd dose. For partially vaccinated adults, complete the 3-dose series no matter how long since the last dose. For those with a history of 3 doses, give 1 additional lifetime booster. The National Foundation of Infectious Diseases, NFID, held a healthcare personnel immunization summit in November of 2017. This included experts for professional healthcare organizations active in infection prevention and control, occupational health, and immunization programs. The purpose of the summit was to discuss how to best optimize practices that will lead to improved immunization rates among healthcare personnel. The summit identified 5 issues to address, including lack of accountability, no consensus on use of mandates as a condition of employment, inconsistent implementation and performance metrics, lack of targeted messaging, and disproportionate emphasis between influenza and other vaccines recommended for healthcare professionals. The next few slides summarize my thoughts regarding practical applications emerging from summit discussions around these issues. There are 6 key groups of stakeholders related to healthcare personnel immunization programs, including various professional organizations, formal leadership, including healthcare chief executive officers, mid-level healthcare managers, and healthcare personnel immunization program directors. There are also informal leaders within organizations, the healthcare professionals themselves, the public or patients, and supportive partners. All of these stakeholders have various roles that can influence the success or failure of a healthcare personnel immunization program. This slide lists the roles of various national professional organizations, including actively support and encourage comprehensive ACIP healthcare personnel immunization programs, emphasizing all vaccines, not just influenza. It is essential to encourage development at the national level of consistent immunization standards for all clinical settings, including supportive policies emphasizing immunization of all personnel that have patient contact in those settings. This is the role for upper-level public health leadership, like state health officers through the Association of State and Territorial Health Officials, ASTHO, the National Association of City and County Health Officials, NACHO, and the Centers for Disease Control and Prevention, CDC, influencing other organizations and policymakers at the national level. This underlines the important role of advocacy for public health at the national, state, and local levels. The definition of advocacy is to actively promote a cause or principle involving actions that will lead to a goal your organization has selected. Please note that advocacy is not just about promoting a principle, but moves to specific actions to accomplish the goal. This implies that advocacy requires a significant amount of strategic planning to identify realistic, specific actions. Pre-advocacy work starts with data collection and analysis. Pre-advocacy data may include public health and healthcare data to identify objective or scientifically real needs. Community needs assessments will provide insights into the perceived needs of the target group that may be different from the real needs identified by science. Political environmental assessments are important to determine the position of leaders or government, local, state, and national, and other organizations regarding their interest in the issue. It helps to review stakeholder strategic plans, including those of not only allies, but opponents. Knowing allies' strategic plans give insight into their priorities based on their beliefs and values. Their priorities are what they will invest resources in. If healthcare personnel immunizations are not in line with their priorities, even if they don't oppose the program, they likely will not support it with resources. It's obviously more comfortable to engage with groups that are on the same page or in the same choir, yet trying to understand opponents' positions and strategies is extremely helpful in developing advocacy strategies. Data analysis should result in a detailed advocacy strategic plan. Advocacy needs are generally greater than advocacy reality. The primary target of realistic advocacy should be in the area of primary emphasis, the area that includes stakeholder interests. That's the area of low-hanging fruit, where all stakeholders are ready for action on the issue. They just need to be organized around a collaborative plan. This is the area where advocacy resources will be most effective in the short term. Secondary advocacy targets require strategies to increase stakeholder interests for future advocacy work. Secondary targets often require community engagement strategies and techniques to facilitate changes in the cultural beliefs and values of stakeholder groups to eventually get to expanded advocacy interests. So key attributes of advocacy include active promotion of a cause or principle leading to specific actions to accomplish the goal, development of primary and secondary advocacy strategies, often involves working with multiple stakeholders. This underlines the importance of coalition skills and competencies for advocacy leadership. The last bullet on this list is important. Contrary to common opinion, advocacy is not always confrontational. Advocacy can be non-confrontational, confrontational, or both. I personally feel that the non-confrontational approach is best in most, but not all situations. This generally takes time and requires patience. It's not as publicly visible, requires persuasion skills that often rely on relationships. Relationships are not built in a few minutes or hours, but require a significant amount of time and patience. Compromise is often part of non-confrontational advocacy, seeking common ground, that area of low-hanging fruit with wins for all stakeholders. Non-confrontational advocacy is an example of the community engagement concept of bridging. Bridging starts with meeting the perceived needs of stakeholders, the area of common ground, the primary targets, developing relationships, and utilizing those relationships to eventually move to more controversial issues, including discussions around the underlying beliefs and values associated with those secondary targets. Confrontation is associated with forcing people to do something they don't want to do. It's often called activism and is associated with political and legal actions. Confrontation often results in entrenchment, damaged relationships, and reduced opportunities for future collaboration on issues. Confrontation may win a battle, but lose a war. Non-confrontational advocacy is more interested in the long term, winning the war, not just one battle. Formal leaders of healthcare organizations must want the program. The role of public health is to make the case to the CEOs. Their interest will be in improving profitability and productivity associated with the safety of employees, etc. Points to discuss and address with leaders could include policy clashes between human resources versus infection prevention and control, safety of the patient versus the civil liberty of the healthcare professional, the impact of programs on employee retention and recruitment, and financial impacts of healthcare personnel immunization programs. Programs of interest to CEOs must help meet organizational goals, their perceived needs, the bottom line of their mission. Benefits must outweigh the costs in resources. Necessary actions of the CEO would include establish an immunization program, appoint or hire a director, assure adequate resources, and support key best practice policies, including mandates and policy enforcement. The CEOs of healthcare organizations must be fully supportive as a first step for a healthcare personnel immunization program. Mid-level managers must also support the program. In my personal experience, I've seen mid-level managers undermine, blow up, or destroy programs adopted by leadership. It is the CEO's role to assure that management at all levels of the organization support the healthcare immunization program. That would likely be the second major step in program development. A bulk of the program will rest on the shoulders of the organization's immunization director. The immunization program director must be passionate about the program message, more than just being assigned to that task by the CEO. They must be at the fourth level of program message identification. NIDA identified 4 levels of identification with the message or program, including, first, no interest in a personal change of behavior or becoming a messenger to others. Second, interest in a temporary personal change of behavior, but no interest in becoming a messenger to others. Third, interest in a permanent change of personal behavior, but no interest in becoming a messenger to others. Fourth, interest in a permanent change of personal behavior and interest in becoming a messenger to others. The immunization director must be at the fourth level to be effective. The CEO must assign a person passionate about the program or it will fail. Additional program director tasks will include develop a strategic plan and identify goals and SMART objectives. Goals and objectives must be clearly defined and agreed upon based on appropriate expectations. Let's define the difference between goals and objectives. Goals are long on time but short on specifics. Attributes of goals include defines the destination, defines necessary changes in an organization to move toward the destination, adjusts the mindset to support moving toward the destination, and sets the stage for specific objectives or activities to accomplish the goal. Objectives are short on time and long on specifics. Good objectives should be SMART, an acronym meaning specific or targeting a specific area for improvement, measurable, identify an indicator or metric to determine progress toward obtaining the objective, assignable, specifying who will take ownership and be accountable for accomplishing the objective, realistic, or what can realistically be achieved given available resources, and time-bound, specifying when the objective will be achieved. The director must design an effective evaluation plan. Appropriate monitoring or evaluation for process and outcomes is essential. Process is often measured by member participation metrics. For example, how many employees received their influenza vaccine during a season? Outcome is often a measure of the actual improved health benefit impacting the organization, like how did influenza vaccinations impact employee sick days? The metrics should be fairly well defined by the SMART objectives. What isn't measured isn't appropriately addressed. Other director tasks include integrate with key stakeholders to make the program run effectively, including developing appropriate partnerships with public health and academia. Few healthcare organizations have the research capabilities to appropriately analyze, research, and present and publish findings. This is a key role for collaboration with academic institutions. The director will also need to develop appropriate links with state immunization registries and develop reminder recall systems for their personnel, etc. They will also need to integrate and collaborate with public health to develop a comprehensive communication and education training plan, utilizing social marketing, community engagement, and education venues to encourage personnel participation and appropriately address misinformation. There will likely be need for unique communications plans for leaders, healthcare personnel, and the public. The director will need to be the conduit of communication with the CEO and board on all aspects of the program, including key organizational policy issues. The director has incredible responsibilities and will make or break the program. Engaging informal leaders is a main concept of community engagement. Informal leaders can have a significant influence on the beliefs, values, and ultimately behaviors in their culture or community of healthcare professionals. These informal leaders are known by several names in the literature, including peer leaders, champions, influential individuals in class, opinion leaders, and the definition I feel best describes these folks, horizontal communicators. To utilize community engagement concepts, a group needs to meet the definition of community. If not, community engagement techniques will not work. The definition of community and community engagement doesn't always fit the geopolitical definition used commonly in public health. A community engagement expert would likely define a community using two major criteria. First, knowing each other by first name. This usually means that a true community is limited to 1,000 to 1,500 people, which is approximately the maximum number of people a person can know by first name. The second criteria for community engagement is that the group must demonstrate a sense of shared responsibility for each other. People may know each other by first name, but have no concern for each other's welfare. An example of this would be individuals living in an apartment complex, knowing each other by name, but having no other connection or commitment. Communities can be divided into 5 major groups, including rural towns that meet the community definition and are generally 1,000 to 1,500 individuals in size. Faith-based groups, workplaces, schools. Schools are complex, composed of several sub-communities based on staff, students, further stratified by homeroom, class, school organization, etc. The last group of communities is other organizations that meet the community definition, including ethnic groups, street children, prostitutes, Knights of Columbus, Rotary, Optimists, sororities, fraternities, social media groups, etc. Healthcare workplaces may meet the definition of community and therefore benefit from community engagement concepts. Communities provide powerful venues to improve the health and well-being of the group in primary, secondary, and tertiary prevention. Basic community engagement concepts must be understood and applied to effectively facilitate communities to own their problems and solutions. This slide lists 20 topics used to train public health practitioners in community engagement. More detailed concepts of community engagement are covered in other sessions of the North Dakota Public Health Training Network curricula. Healthcare personnel need to be educated on the true value of immunizations, adequately addressing the bombardment of misinformation from various social media networks. They need to understand that a primary reason for immunization mandates is about patient safety, not civil liberties. Having said that, there should also be an emphasis on the personal safety benefits of immunizations for the healthcare worker. Healthcare workers should also understand that their actions speak volumes to the public. Practice what you preach is really important. People scrutinize what a healthcare professional does. Access needs to be discussed, including where and how they can receive their immunizations. Incentives to participate may be important for those not fully convinced of the benefits, particularly if the organization does not have a mandate policy. The public also needs to be intensively educated on the value of immunizations to counter vaccine misinformation. The message needs to be clear. Immunizations are not only for the healthcare workforce, but also the whole community. It must become part of the belief and value structure of the community and all institutions in the community. This is a role for public health, effectively facilitating community engagement. Community engagement facilitates the community to examine and change their risky beliefs and values, including those related to immunizations. All members of a community must be adequately immunized to protect the whole. This is the concept of herd immunity. Adequate herd immunity can only be achieved when all communities and subcommunities in a target area support immunizations and have adequate access to them. Immunizations not only protect the general population, but also those that are more vulnerable, including infants and those with weakened immune systems. As in the diagram at the bottom of this slide, the most effective community engagement programs are not those that focus on one community in a target area, like a healthcare workplace, but to all communities and sub-communities in the target area. Essentially, a community engagement saturation strategy. Immunizations need to be a community priority, including one for the healthcare workers in all healthcare facilities. Partners need to be engaged, including public health, local and state, pharmacists, academic partners, etc. Coalition building and adaptive leadership skills are necessary to do this effectively. Public health is well positioned to facilitate and train these coalitions in support of healthcare immunizations. Coalition building and adaptive leadership are discussed in more detail in other sessions of the North Dakota Public Health Training Network. For details on the NFID Summit and to download the PDF book entitled Call to Action, Improving Healthcare Personnel Immunization Rates, go to the National Foundation of Infectious Diseases website listed on this slide. In summary, all clinical settings would benefit from mandated healthcare personnel immunization programs. Programs should follow ACIP guidelines. All 6 major stakeholder groups need to be engaged. Public health is well positioned to facilitate immunization stakeholder coalitions. Selection of an appropriate program director is essential for success.
Take your public health practice skills to the next level. Our specialized certificate courses give you an opportunity to work systematically through a public health topic and demonstrate your understanding of that material in a capstone project. Learn more and sign up at ndphtn.com/certificates.